So thank you very much, Morton Kern, for accepting this invitation for the interview. Of course, you are known worldwide, but still, for those few who do not know you, you are a professor of medicine at the University of California at Irvine, and also chief of cardiology at the Long Beach VA hospital. And of course, yeah, widely known, you have enormous expertise in the field of interventional cardiology and also in particular in coronary physiology. So what was very interesting, of course, we go back to the results of the 𝗕𝗿𝗰𝗁 Europe study, where it was shown that the results were inferior to the FFR, although the MACE for the QFR was at about 6.7%, which is really in line with all the major FFR and IFR study. But the strange thing, so to say strange, is that the FFR MACE was at a very low 4.2%, and that made the big difference. Now, what we found at the EuroPCR presentation on the Friday by the team from Aarhus, that they did a correlate analysis of the QFR cases in the study, and they found that in about 10% of the cases, the image quality was poor or very poor and could not be, say, reproduced in the core lab, which is, of course, yeah, it says something about the quality of the data. And that, of course, the MACE with these poor or very poor cases was about, yeah, more than 10%. And if you exclude those and you look at the clinically relevant cases, then we come to, if you look at the curves, at about 5%, which will be much more in line with the 4% of the FFR. And I would like to have your thoughts on these discrepancies. And I think I'm very glad that they did this correlate analysis because it highlights some of the issues in the study.
Well, Johan, thank you very much for inviting me to comment on the study. And again, in the 𝗕𝗿𝗰𝗁 Europe trial, you just mentioned that they were not inferior, and they had a higher, the event rate was higher in the QFR than in the wire-based FFR, predominantly because the wire-based FFR did such a good job and had such a low rate.
Yeah.
In addition, there were some errors that are intrinsic to all of the angiographically derived FFR systems that can create problems, such as poor angiography, poor analysis of the vessel, movement, errors in interpretation of the overlap of the vessels. And if you include these into the studies, of course, you decrease the quality and you may identify or miss things that you need to exclude. Now, the reanalysis by the Aarhus physicians shared with us that when you get these angiograms of quality for analysis, that the event rates are in line with all of the other studies that were done with FFR angio. So it's not a surprise. It's just an unfortunate turn of events that the study group for the 𝗕𝗿𝗰𝗁 Europe didn't do the best job on angiography. And we emphasize that for all of the systems that are using these tools to get good angiography. So I know people are going to say, well, a reanalysis of a study is, a second bite at the apple. But it does support the fact that as a group, FFR angio systems work. They are comparable both to one another and close to FFR wire. It would be unusual that FFR wire would have such a big dominant role. It was interesting that it had such a very low event rate associated with it, lower than the FAME studies, lower than a lot of studies. So I think this is helpful. And it does encourage people to consider the use of the FFR angio systems and particularly QFR as still quite viable. I mean, this does not negate the value of this technique.
Yeah. And the question, of course, is, in going forward also, how can we try to make sure that the angiograms that are made on a daily clinical basis get a little better quality? As what we are trying to do also is in our solution come up with a deep learning approach that indicates to a particular acquisition what the quality is, whether you have overlap and poor contours, whether the noise ratio is too high, etc., etc. And I would hope that helps a little bit in improving the quality of the angiogram. So what do you think of such an approach?
Well, I think that's excellent. And it's already in place in some systems that have a disqualifier for a particular angiographic view, in that its angulation is too short, there's too much movement, or the image is not shown, the lesion is not depicted. And then it puts a red box around that angiogram and says, don't use this one. Yeah. And that tells the operators they need to, reshoot or pick another way to get the information from the angiogram.
Yeah. And that is, of course, with the wires also. You have to take the proper precautions, otherwise the wires also do not work. And we have always assumed that if you take a proper clinically relevant angiogram, that it is good enough. But apparently our bars, the quality requirements keep on increasing a little bit.
Yes. And so it's a good point you make. The FFR wire is not without potential error as well. And if you rely on the wire, you better have your technique in order and well performed. Otherwise, you're going to get an erroneous FFR.
Yeah.
It'll be interesting to see who relies on the non-hyperemic pressure ratios to get a correlation to the FFR angio number, because that is kind of a question that's still outstanding in the field. How good is it to project a non-hyperemic ratio? At the moment, I think FFR wire with adenosine is still the standard, and that's what we should be comparing things to. And then if people want to do some more studies, get the IFR, get any of the other non-hyperemic pressure ratios, they can. But why take a second best item? Mm-hmm. And so I would say FFR is the way to go, with good technique, of course.
Yeah. In the past, of course, we have been in the field with the QCA for a very long time, as you know. And we also have often seen that hospitals and cath labs that use QCA by itself already spend more time on making good images. And now with the more widely use of the angio-based solutions, we hope that trend will continue. That, say, looking at the images, getting at the results, if the images are of clinically relevant quality, then an angio-based QFR or whatever the technique is should be relatively easy. And so it helps also the interventional cardiologist by looking at the quality and do a proper job, and then you get quite simply, actually, you get good results that are clinically useful.
Well, what you say is exactly right. I think in clinical practice, the way we do things here, we're always in a little bit of a hurry to get the images. Oh, did we get the lesion? Yeah, we got it, but there was these artifacts and there was overlap, and we didn't take the time to just relax, get a nice image, make sure it's good, and then get another image. We like to go from image to image to image, and we forget that if we're going to employ these tools, we got to do them right. And the first step is a good angiogram.
Yeah, no, absolutely. And you've taught the whole community over all your life about angiograms and making good angiograms, and all your textbook. I mean, they're all based on basically getting the best out of these angiograms. And I hope that the community continues to read your books, your textbook, and listen to your presentations, because they are extremely worthwhile, of course, and thoughtful for the daily clinical practice also. And I hope that with your work in this field and what we try to do, we hope to get, in the end, the best for the patient also.
Absolutely. And thank you for that kind comment. I appreciate that. I think this is an advance, and all of us who work in this field should recognize the step forward that angiographically derived FFR and QFR among them is making, and has the potential to make for our patients.
Right. Well, thank you very much, Dr. Kern. It was a pleasure talking to you on this, for us, what is a Thursday evening, and for you somewhere mid-morning, I guess. But it was a pleasure talking to you, and I'm sure we will be in contact in the near future again. Thank you so much.
My pleasure. Thank you very much, Johan.